Well, welcome everybody. It's great to see you, and for you, we thank you so much for joining this NHS Cancer Programme's third round of the Innovation Open Call. And we're delighted that many of you can join us today. For those of you who don't know me, my name is Richard Gilbertson. I chair the Department of Oncology and direct the Cancer Centre at the University of Cambridge, but also I chair the Innovation Expert Advisory Group for this particular programme within the NHS Cancer Programme. So as you know, you're joining us today. We're excited to announce the third call. We're committing £15 million to this, and this is focused on identifying and implementing late-stage innovations that will really support early cancer diagnosis. We've got a great agenda ahead of us. I'm delighted that my friend and colleague, Professor Peter Johnson, will be joining us from the NHS Cancer Programme. We're also going to hear from Gillian Rosenberg, Katerina Lombardo, on how the Open Call 3 will support national priorities and who can apply for this call. And also, obviously, we'll have time for Q&A. Just in terms of that, Professor Johnson will have to leave us at 4 o'clock, so he won't be available for the second call. Just a few Q&As, housekeeping issues before we start. If we could bring up the slide on housekeeping. First of all, please use the Q&A box. If you've got questions as we go along, don't put those in the chat. Just use the chat for any technical issues. The slides and recording will be uploaded on the website after the webinar. And if you've got any other questions, there's an email address there you can send those to. Okay, so I'm now going to hand over to Peter, who's the National Clinical Director for Cancer at NHS England. He's going to take us through the programme and priorities.
Brilliant. Thanks very much indeed, Richard, and thanks to everyone for joining. So we will get straight on, and I will talk a little bit about the background to this and why the NHS England Cancer Programme wants to invest in this particular area and what our priorities are. So can I have the next slide, please? Our dominant priority is to drive up the rates of early cancer diagnosis in order to improve survival from cancer. So in order to do that, we have set ourselves a target of diagnosing 3/4 of cancers at an early stage, stage 1 or 2, by 2028, and at the same time to improve the experience of cancer patients during that period of investigation and diagnosis, and of course into treatment and beyond. Next slide, please. So the principal aim of this call is to help us to enhance our early diagnosis strategy. Next slide, please. At the moment, the diagram on the left here shows you the proportion of different types of cancer which we diagnose at an early stage, at stage 1 or 2. So the horizontal axis, as you go to the right, we diagnose more and more cancers at an early stage. So you can see on the right-hand side there, breast cancer, melanoma, testicular cancer, uterine and thyroid cancers are generally diagnosed at an early stage in the great majority of cases. And on the vertical axis is the number of cancer diagnoses per year we make in each of these cancer types. And what you can see is that whilst we have some cancers where we're doing really quite well, there's a large crowd of cancers, some numerically important ones such as lung cancer and bowel cancer, but also a whole range of other cancer types where there's significant room for improvement in the rates of early diagnosis. And if we look historically on the right-hand side here, this is over the last decade where we have been with the rates of early cancer diagnosis, which is a stubborn about 55–56% of cases being diagnosed at early stage. So it hasn't really moved that dial up until prior to the pandemic, when we first started implementing the long-term plan for cancer. Next slide, please. So we have a number of incremental gains that we think we can make in improving this early diagnosis rate, and they're set out on the waterfall diagram on the left-hand side here, starting with the starting position of around 55%, and then a number of different activities in different areas, including encouraging people to come forward by raising public awareness of symptoms, streamlining referral pathways, working with primary care to help them to select and refer effectively, trying to do more case finding, proactive case finding, optimizing our screening, in particular increasing screening uptake, and doing a variety of other things. But you'll see that on the right hand side there, there's NHS funded innovations, and we'll talk a bit more about the detail of that, but essentially there's still a significant gap for raising the rates of early diagnosis. And it's there that we're keen to invest, to partner with industry, to partner with other NHS organisations to see what further we can do. Next slide, please. So, as I say, we've been investing in timely presentation, and as a result of the awareness raising public campaigns, the Help Us to Help You campaigns about cancer, we've seen that referral rates for suspected cancer diagnoses have been higher since the pandemic than ever before. What you can see is the blue line compares the cancer referral rates compared to before the pandemic, and the orange line to since last year. And you can see that it's gone up about 10% in the previous year, and it's gone up about 120% since the pandemic. And that's very much the historic trend, that urgent suspected cancer referrals have gone up about 10% year on year for the last decade. And that's a sign in some respects of the success of the campaigns we're running, although of course that at the same time has put significant pressure on the diagnostic system downstream to manage this very large number of referrals that's coming through, which is more than a quarter of all GP referrals into secondary care at the moment, and adds up to about 3 million people in the last year. Next slide, please. As I say, we're working with primary care to try and help to streamline the process, to make it easier for people to get diagnoses. We're working on putting digital support tools on GP desktops to help them with sifting through the symptoms with which people present. We've also run out a program to expand GPs' access to tests for people who don't meet the criteria for referral, CT scans of the body, MRI scans of the head, and ultrasound. And we've been using things like the fecal immunochemical testing to triage referrals for suspected lower GI cancer. And also we're working on rolling out teledermatology, dermatoscopy, to send high-quality images of skin lesions in so that they can be triaged remotely without people having to attend skin clinics to see whether they need excisions. So lots of work going on in helping to make things easier for GPs. Also working with community pharmacies. You'll have seen in the news last week, lots of emphasis on what we can do using this huge resource in the community. And we're piloting at the moment whether it's possible to pick up more cancer referrals through the expertise of community pharmacists as well. Next slide, please. As well as these initiatives through what you might call the more traditional referral routes, we've also been proactively going out and trying to improve case finding. And in lung cancer in particular, we've been rolling out our targeted lung health checks, which is essentially inviting people who meet the risk criteria, who've ever smoked, in for a mobile CT scan carried out as close to them as possible. We've invited more than 1 million people now. In fact, it's more like 1.2 million people now, and we've already diagnosed more than 2,500 lung cancers through this route. Most importantly, on the right-hand side of this slide, the people that we have picked up through the targeted lung health checks, 3/4 of them have lung cancer at an early stage, as compared to at most about 1/3 of people previously if we just waited for them to develop symptoms. So we've demonstrated, and we're rolling this program out, and it's now destined to become a national screening program, that we can do this, that we can pick up a lot more cancer at an early stage. And very encouragingly, the diagram on the left here shows you the rates of early diagnosis broken down by deprivation quintiles. And historically, many cancer types are much less likely to be diagnosed at an early stage in the least well-off people in society. And the red line here is the most deprived group. And you can see that back in 2018, that was pretty much towards the bottom of the probability of getting lung cancer diagnosed early. Now, we've been focusing our lung health checks program in those parts of the country, in those areas where we have the biggest problems with lung cancer incidence and late diagnosis. And what's really encouraging is that has resulted in an inversion of this relationship, whereby the most deprived groups are more likely to have lung cancer diagnosed early, directly as a result of the targeted lung health check screening program. And you can see that red line is now at the top rather than the bottom of the list. And the reason this is important, of course, is that it demonstrates that by some targeted investments, some carefully thought out intervention, by getting the community on board, and perhaps most importantly, by thinking about how to lower the barriers for people to come forward in those groups who traditionally find it more difficult to access healthcare, that we can actually move the dial on this, that we can make a difference and and overturn the historic deprivation scale that we've seen with this kind of innovation. So we're looking for the sorts of things that will help us to do this in other areas. Next slide, please. So we're looking for cancers of other types. We know we've got a big problem with pancreatic cancer with late diagnoses, because pancreatic cancer, unfortunately, often only presents when it's spread locally quite extensively. So we're working with Pancreatic Cancer UK and the European Registry to make sure that we're doing increased surveillance for those with an inherited high risk of pancreatic cancer. And we've also got some pilot programs coming up looking at screening for pancreatic cancer, for example, in people recently diagnosed with type 2 diabetes, where we know the risk of pancreatic cancer is higher. We're also working on screening for liver cancer, hepatocellular carcinoma, particularly among those with a high risk of cirrhosis, whether it's alcoholic or fatty liver disease or hepatitis infection. And again, we've got some mobile trucks going out doing fibroscans in the community to help to identify those people who are most at risk of hepatocellular carcinoma and enroll them in surveillance programs. And finally, last week, we launched openly our BRCA finding initiative in the Jewish population, where we know that 1 in 40 people of Jewish ancestry are likely to carry a BRCA mutation predisposing them to breast cancer, endometrial cancer, and prostate cancer. And now that's now live and launched, and very high uptake of people coming forward for testing for that. We've also been working on our Lynch syndrome screening, whereby people who are having operations for bowel or endometrial cancer, the tumors are assessed for mismatch repair deficiency, and then we're going back in those cases where we find it to see whether this is a result of a germline predisposition of DNA mismatch repair. So a lot of work going on into prospective case finding. Next slide, please. We're also working in the innovation space with the Grail company to pilot a blood test which is capable of picking up a number of different cancer types using minute amounts of circulating DNA and the chemical changes that take place in DNA early on during cancer development, so-called changes in methylation. And this is a large prospective randomized blinded trial to see whether this will work in practice. So we've recruited 140,000 people to have a blood test every year for 3 years. And we're currently halfway through the 3rd year of blood testing to see whether the 70,000 people in whom we test the blood for the presence of methylation abnormalities, and then in those cases where we pick up an abnormality, investigate them for possible cancer, as compared to the control group who we're managing in the usual way, which is to say only investigating if they come forward with symptoms. And we'll start to see the early trial results from the prevalence screening round of this program in the spring of this year. So we'll start to look at the results of the 1st year of blood testing to see whether it does indeed help us to detect cancer at an earlier stage. And we'll think about at that point whether or not we roll out a larger pilot over the next couple of years for up to 1 million tests to see whether this works in real life. Next slide, please. So we've had a number of innovation calls, and we've already awarded just under £25 million to pilot or scale up some of the innovations which are already close to applicability. And there's a few examples given on the slide here. The pinpoint test is effectively using a series of routinely measured blood parameters with an AI algorithm to see whether we can pick up cancers at an earlier stage in primary care, particularly. Endoscope Eye, which is an adapter for a smartphone to use for head and neck cancer diagnoses, and Modality LLP is a biomarker approach to ovarian cancer. And Alexis GAAD is a clinical algorithm to look for the early detection of hepatocellular carcinoma. So these are all programs which are already being supported. Next slide, please. The purpose of the call today, obviously, is to see if we can find the next generation of these types of innovation. And Gillian's going to go into more detail about the exact parameters and the sort of things we're looking for. But really, we are very keen to hear from commercial partners, NHS organisations, for innovations that might help us to get towards our 75% ambition. Next slide, please. The encouraging news is that we're already starting to see an uptick in the rates of early cancer diagnosis. This is the data over the last couple of years. You'll remember I showed you a completely flat line up until 2019. What we've seen since the pandemic, as we've come out of that and as we've been driving up the numbers of referrals, is that we are seeing increasing proportions of people being diagnosed at an early stage. It's about 2 percentage points higher than it was prior to the pandemic. And obviously what we really need to do is make sure we're sustaining this progress and driving forward on this. Next slide, please. This is a slightly different way of expressing essentially the same data. This shows you through each year the rates of early cancer diagnosis from the cancer registries, broken down by year. You can see 2018 is the grey line towards the bottom. 2020 is obviously the pandemic, where we saw a big dip very early on in the springtime when the first wave of COVID hit, and then a recovery of that. But perhaps most encouragingly, the green line, which is incomplete because we only have data on this slide up to May of last year, we're running along above all previous years, even above 2022, where you can see that we had historically high rates of early diagnosis. So it feels as though with the targeted interventions we've been making all the way through from public awareness, through GPs, through referral pathways, through diagnostics, that we are starting to move the dial on this. And obviously what we'd like you to help us do is to make further progress on this. Next slide, please. At the same time as we've seen progress on early diagnoses, we see a persistent gradient in the rates of early diagnosis according to deprivation. So I showed you the data from lung cancer earlier, where the lung screening program, the targeted lung health checks have really inverted this relationship. But if you take it across all cancers as a whole, what you can see here is a very persistent pattern whereby those in the most deprived quintiles have a significantly smaller likelihood of having their cancers diagnosed at an early stage overall. And it's around sort of 8 percentage points difference between the worst and the best. And that's what we're obviously very keen to try and close up. So we're particularly keen to hear from people who might have ideas about how to particularly address those in the most deprived quintiles of society, those who have the most difficulties in accessing healthcare as a matter of routine, and anything which can help us to close the gap and to really bring up those people who find it most difficult would be especially welcome. So that, I hope, has set the scene for both where we think we've made some early progress, where there's certainly room for more progress, and really the determination in NHS England that we invest in things which will help us to close this gap and to help to drive up the rates of early diagnosis. So I will stop there, but we'll pick up any questions, if we may, in the Q&A session a bit later on.
Great, thank you very much, Peter. That's a very clear presentation. Thanks for keeping to time. I've seen a few participants raising their hand. Just to remind you, please, if you have questions, type them in the Q&A. There's a Q&A box at the bottom of the Zoom menu where you can type your questions into, and we'll get to those next. I'm delighted now to introduce Gillian Rosenberg, who's the Transformation Lead for Innovation at NHS Cancer Programme, and she's responsible for the Innovation Open Call. So Gillian, thank you for your presentation.
Thanks, Richard. And thanks all of you for coming and joining us at this webinar. It's really exciting to have you all here to launch our open call. I'm just going to give you a bit of information about who we are as an innovation team and why, in fact, we are running this call. So next slide, please. These are our ambitions, well, I guess our aims as a innovation team within the National Cancer Programme. And the first of those is to identify innovations that support our long-term plan ambitions. And as Peter has highlighted, we are focusing on early diagnosis because we don't yet know all of the interventions that we need to implement and deliver at scale across the NHS to get us to our 75% target. So what innovations are we interested in? Well, essentially anything that can help us identify and diagnose people earlier than they are currently being diagnosed. So that can involve looking at who's at risk, either in the asymptomatic or early symptomatic patient cohorts, and encouraging them to come forward, and crucially, encouraging those who are less likely to come forward at the moment to come and present to the system. Also looking at new or improved tests to help us diagnose cancer in these patient cohorts, and better ways that we can design and deliver our pathways to support the early diagnosis of these patients. So one thing I do also get asked quite a lot is, Are we interested in diagnostic capacity and efficiency tests? And the answer to that question is maybe. It depends if it can help us with our early diagnosis. And I guess I normally then ask 2 questions back on that, which is, where in the pathway are these tests sitting, and can they be moved earlier to a primary care or community setting to perhaps target a different cohort than we normally see in our secondary care post-referral settings? And can it be combined with interventions that increase uptake? So if you're thinking about the whole pathway, that you then have a better designed pathway that brings more people in and then more effectively triages and prioritize those who are most at risk. The second of our aims is to support innovations to deliver successful projects. And by that, we mean projects that are real-world implementation pilots that can really provide evidence of impact and feasibility if things were to be scaled in the NHS. But crucially, it's that they provide evidence that will inform our onward decision-making about spread and adoption. So that can be evidence that can support NICE appraisals or commissioning decisions, business cases, support clinical endorsement, improving patient uptake. All of those are the kind of evidence that we're interested in generating with our projects. And then finally, we really want to speed up the path from the innovation and from these pilots into business as usual. So there's a couple of ways which we think about this. First of all, as I said, we want our pilots to be developing evidence that can inform onward decision making. We know it's not just enough to generate the evidence. We need to make sure that the key decision makers engage with and understand the evidence and buy into the innovations. And then we also think about what we can do in parallel as opposed to sequentially. So we don't always need to wait until a pilot is finished and an evaluation has been published before we can start engaging with the system and prepare them for innovations if we think that they are going to be potentially useful. So for us, the main vehicle by which we achieve our aims as an innovation team is through this innovation open call. Next slide. So what's our specific role within the open call? Well, first of all, we provide the funding for the open call projects, but I think we know that providing funding isn't always enough to help projects be successful. So we really want to be on hand to be able to provide advice and implementation and how to overcome the barriers, both in the delivery of the pilot and in wider spread and adoption plans. Help with the understanding of the patient pathway from a patient perspective, a clinical perspective, an operational perspective, so we can best understand the potential impact of an innovation. We're looking quite a lot at making sure that we can create links with key stakeholders and other programs across the NHS who will support our innovation projects to deliver or could be impacted by the innovation and be involved in future uptake of the intervention. And also helping our innovations support long-term strategies for that wider implementation so that those who are successful can go on to the next step. Next slide, please. As has been highlighted, this is our third round of our open call. So we've had 2 rounds so far, invested, well, it says over 21 million there, but as Peter said, closer to 25 million. We have 14 innovations that we are currently supporting. Our innovations partner with Cancer Alliances and with Health Innovation Networks, and we have the potential for 160,000 patients to be involved in our projects. And I think to date, 30,000 patients have participated in one of our open calls projects. We are happy to support any type of innovation, and here are all our innovations listed here. So these include medical devices, we have AI tools, we have interventions that increase uptake, we have clinical pathway redesigns, and over any type of cancer. So again, these cover a range of different cancer types. I think the key thing really for us is anything that can help us support our early diagnosis ambition. If it's in the right late stage, ready for real world implementation, we are really interested to hear from you. Next slide. The last thing I just want to touch on before I hand over is that one thing we've really learned is that the innovations that are most likely to succeed, both in being funded, but then in onward implementation are those that partner with health innovation networks and/or cancer alliances. So if you're not aware of these organisations, so health innovation networks support innovations with spread and adoption in their local area, and cancer alliances have oversight for the delivery of cancer services in their local area. And I think you'll hear a bit more later about opportunities to get involved and how to find partnerships and also the benefit that these partnerships can have. So I guess this is really kind of all I wanted to say from us as an innovation team and what we do. Really excited that you have all joined us here today, really excited to see what innovations are coming through. And then I think I'm handing over next to Katerina, who's going to give a little bit more detail about the specifics of the call and what's involved.
Yeah, thank you very much, Gillian. So as Gillian said, I'm delighted to pass on to Dr. Katerina Lombardo, who's actually at SBRI Healthcare, who's a program leader for the competition. So Katerina, thank you so much for your presentation.
Thank you both for the introduction and good afternoon, everyone. In the next few slides, I'm going to give you a bit more details about what this upcoming call and what we're looking for. So if we can go to the next slide, please. I think I'm going to spend some time here. Also, I've seen a few questions coming on some of these points, so hopefully this will clarify. As Peter said, we're looking for innovation that will address the early diagnosis and detection of cancer. But when we say innovation, we really mean it in the broader sense of the term. So, of course, the usual suspects, medical devices, in vitro diagnostics are eligible for this call. But we're also welcoming applications on behavioral interventions or new models of care, software, so really very broad. What we are not looking for here is to fund treatments or innovation that is not backed by strong evidence or that is not compliant with regulations such as GDPR, or that might exacerbate health inequalities. And also to flag that for this call, we are not looking to fund workforce training or wellness apps. This is outside of the scope. And then onto the stage of development, we are looking for mature innovations. This is because we really want products and innovations that are ready to be implemented in the NHS. So if this is the case for you, you must have regulatory approval in place, or must be in use, at least in one trust, as standard routine care. We are not supporting innovation that is at an early stage and needs further development. And in terms of which organizations can apply, you can be a lead applicant if your organization is based in the UK or the EU. However, your clinical sites must be based in England. So I think this might answer some of the questions we had in the background. If you have an innovation that is exciting and is really good fit for this call, but you are outside of these regions, don't worry, because you can still apply as a subcontractor, but you must partner with one of the organizations based in these regions. In terms of the projects, we are funding real-world implementation studies. So we're really looking at stuff that can be implemented in the NHS and in England and evaluated. We won't fund product development nor randomized controlled trials to look at safety, efficacy. This stuff should have already happened when you apply for this funding. And also, if your project is focusing on generating evidence to influence NICE guidelines, this is not really the program for you. This could be a side outcome of your project, but we're looking at gathering implementation information. And your projects must be up to 24 months long and not spend more than £4 million net. This shouldn't include marketing costs. If we go to the next slide, please. I'm gonna tell you a little bit more about the assessment, which I won't lie, is quite thorough. So please do take the time to read all the guidance that we're going to publish online in the next few days and weeks, because this will really support you in putting together an application. Once you submit your bid, this will be reviewed by a mix of experts with complementary expertise. The NHS Cancer Programme team will look at eligibility and also at the alignment with their priorities. And once, if you are successful and are shortlisted, you will undergo further peer review, public review, NHS England will offer a number of experts to look at different angles of the project. Is the evaluation plan good? Does it align with current programs? And what's the impact on early diagnosis of cancer? You will be invited to present in front of a panel of experts. There will be a Q&A. And if you are recommended for funding, you will only be funded after thorough due diligence is passed. If we go to the next slide, please. I'm going to give you some more details about what we expect to see. So I spoke about the entry point earlier. And in terms of the project, as I said, we're looking at real-world implementation studies, but you shouldn't be surprised to see all the bullet points really in this square, because overall, all these aspects should be considered if you're putting together this type of project. You might need to readapt your technology for the implementation. You will need to train staff. Might need IT integration. Also, if you're looking at implementing in the NHS, you must have a carbon reduction plan in place or putting one together, thinking about health inequalities, patient and public involvement, your health economic case. And in particular, all of the projects must have a work package on an independent evaluation, because we want you to measure outcomes so that you are ready for your next step. We are expecting something very tangible out of these projects. You must be either ready for procurement when you finish, so you must generate the evidence that you need to go on through procurement frameworks, or if you need to raise further funding, you need the evidence for that. So we really would like you to bring you to the next step or procurement when you finish. And if we go to the next slide, please. And don't worry, I'm not gonna go through all the bullet points here, but just a few things I wanted to flag. In terms of funding, differently from other funders, we provide 100% SME, we cover up to 100% SME costs, and for all the organizations really. However, you need to budget your project at a fair market value. This means that you don't have to use full economic costing, or you don't have to include any profit in your budget. After all, this is public money you will benefit from. Also, in terms of the contract, just take some time to have a look at the terms and conditions, because they're non-negotiable and they are available online. And I know I said, and I asked a lot of things so far, but be reassured that if you're part of our portfolio, you will get a lot back from us, because you will be supported by an individual program manager for your project. Also, NHS England will join monitoring meetings. You will benefit from one-to-one sessions with NHS England experts in implementation, evaluation, and also health inequalities. We will offer the NICE Meta tool and also events and opportunities to link up with relevant stakeholders, because we really want you to be successful at the end. So just the last couple of slides from me, I think. If we go to the next. Take note of these dates. We will keep anyway publishing on our social media and website updates, but the call opens for submissions on the 8th of April, 29th of May, 1 p.m. is the submission deadline, and the whole process should really end towards end of October, November. And last slide from me, just to flag a few upcoming support events that we're gonna run. If you have an innovation, but you're looking for partners to deliver your project, apply to join our virtual matchmaking event, because Cancer Alliances and Health Innovation Networks will be in attendance, and you might have an opportunity to find a good partner. We will also host a workshop on how to put together a good application just before we launch the competition. And when we have launched, we will host a Q&A session. And I think that that's all from me. So I hand it over back to our chair. Thank you.
Thanks, Katerina.
And so next slide. So thank you.
Great, thank you. So we're now in our Q&A session, first Q&A session. Just to remind you that Peter Johnson will only be with us up until 4 o'clock, so please continue to type your questions in there. I'm just going to go through these, only addressing all those that have need to be answered live, and I'm just going to do those in the order that they appear. So the first one is for Peter. Peter, You noted that you still have GRAIL contributing 4.5% movement towards a 75% target, even after the recent Lancet paper showed they're not at all good at stage 1-2. Can you explain that? And also that you really only expect all of the NHS funded innovations to contribute to 1% collectively. So that's the first question, I think, to you, Peter.
Thanks. I mean, I think one has to take these percentages on the diagram with a bit of a pinch of salt. I'm not quite sure which Lancet paper you're referring to. If it's the one about the Simplify study, that was in a symptomatic population, so that's a slightly different group to the one we're talking about here. The answer is we will see when we start to see the data what the magnitude of impact is. This is modeling data from the case control information that we have about asymptomatic populations tested in the States. And certainly we would like to see the funded innovations contribute more than 1%, and anything we can do to increase that, obviously the better.
Thank you, Peter. Next question is from Dimitri, either for you, Peter, for Gillian, or for Laura at SPRI, and that's, could you please let me know what regions have the highest rate of lung cancer being diagnosed at late stage?
Historically, and this is where we've been concentrating the targeted lung health checks, we've done it in smaller areas than regions, but historically it's those areas of highest deprivations. So big patches in the northwest, the northeast, and the Midlands in particular, with also some smaller areas around London, the penumbra of London, and some small areas in the southeast. But that's where we've primarily targeted the lung health checks up until now, although we're, as I say, rolling it out to a national programme.
Thank you, Peter. Question from Hector. Just saying, Peter, congratulating you on the wonderful data in your presentation, but wondering if it's publicly available and where you could recommend going to access it.
I think we're planning to make the slides, the information in those available in a report following on from the meeting, and there is publicly available data on the NHSE and the National Data Registration Service sites.
Thank you. A few questions on melanoma. The next one is relating to that, and that's, do you sponsor applications that have solutions to cancer that are already diagnosed early, such as melanoma? Gillian, I don't know if you want to answer that, or Peter.
Yes, Gillian, for a change. Here you
go. So we're happy to look at any cancers. There are no cancers that are excluded from this. What we would ask is that you can demonstrate how you would improve the early diagnosis rate within that cancer type. So if you can show an increase, then great.
I think that also answers one of the other questions, which is there a specific list of cancers? Not particularly. I think we'll be interested in any cancers that basically fulfill the mission of this particular call. Next question from Steve at Sendo Supplies, quite a long question. We're working with technology that can significantly increase the number of cancers detected at stage 1 and 2. This test is currently available in India, where it was developed, but has not yet obtained UKCA regulatory approval. This might be in place before the application closes. What if it isn't? Would such a breakthrough in cancer diagnostics be overlooked in the absence of a UKCA? I don't know, Gillian or Peter or Katerina, do you want to answer? Maybe Katerina, would you like to answer that one?
Yeah, I can start and feel free to chip in. In principle, as I said, either you are in use in standard of care somewhere in the NHS, so you might not have approvals, but you are used outside research settings in the NHS. Otherwise, you really require to have your approvals in place. If when you submit your application, you can at least demonstrate that you have requested the approval for UKCA, but there is a limit to the risk that we can take. If there are any issues that might delay this for you, then we wouldn't be able to support the project. So last year, we gave a grace for completing this process until the shortlisting meeting, which this year should be in July. But if it's not available after that, you might wait for further opportunities. And there is also the point to make sure, and Julia, maybe chip in, the evidence that you have generated abroad also is applicable for implementation here. I don't know if there is anything else to add.
Did you want to add to that, Gillian and Peter?
Yeah, I mean, I think the key thing that we're looking for is some level of feasibility within the NHS. So even if it's only in a very small setting, and that's often where partnerships with Cancer Alliances or support from the Health Innovation Networks can help with outlining what that might look like, and how to obtain that.
Okay, thank you. A couple of questions also on AI. One frequently debated topic is a subject of the next question, which relates to legislation around AI. So we've said obviously that we support AI innovations, but current legislation has not changed and companies can't use AI interventions without clinical input. So the question is, what's the advantage? And it may be a bigger question, which we probably don't have a crystal ball for, is will the legislation change soon? So Peter, I don't know if you want to address legislation as it relates to AI in this particular call.
Not specifically. What I would say is that there are lots of potential AI applications in relatively advanced stages of application in the NHS. As you rightly say, all of them require a degree of clinical input, but in terms of streamlining clinical workflows, reducing waiting times, increasing efficiency, and so forth, those are all potentially relevant readouts from those. So I think AI innovations which help to improve early diagnosis and improve the diagnostic process and thereby reduce waiting times would certainly be things that we would consider in this program.
Thank you, Peter. There's a few comments also in the questions, but not really questions relating to requiring support. So just to remind you, there's an email address associated with this, and if you're looking for support or further input, please feel free to direct those comments to that email, and we can certainly get support out to you and address those issues. Another question that's come up relates to a devolved nation. So could a clinical site in England partner with a clinical site in Wales to put a joint project with an industry partner together? Katerina, I don't know if you want to address that one.
We will fund sites in England, so you're free to expand beyond that, but the focus of this funding will be for sites based in England.
Great.
So, yeah.
Interesting question from an anonymous attendee. If we have to fly samples to the US, for example, for an analyzer test that's not available in the UK, this would fall foul of the NHS net zero agenda and make our innovation ineligible for partnering. Could we clarify that? So if we need to do tests that maybe are only available currently in another country. Gillian?
I think for the project and the pilot, that would be fine. I think if you're talking about what your longer term adoption plan is, and how feasible this would be long term, then that would be something that should be, factored in, where the test would be taking place, how much that would cost, and the net zero implications.
And next question, do we need to include the commissioning of an independent evaluation if we plan to evaluate the clinical effectiveness of the innovation within the project proposal?
Shall I chip in with this one? Yeah, but the commissioning of an independent evaluation is a mandatory requirement because it is what it will ultimately give you the robust evidence that you can present in front of commissioners or whoever is going to use your product going forward. So you will need to include that, and it has to be independent. So it has to be run by a different supplier from yourself. So I hope that helps.
Thank you. Next question from Sharon. Can I clarify that a randomized clinical trial would be acceptable providing the outcome was not safety and or efficacy related? Again, Katerina, maybe you'd like to address that.
I'll start, but I get Gillian to chip in because we had quite a lot of discussion on this. And I think that our main point is that if you need to use a comparator, we wouldn't want you to run something against a comparator during your implementation. You can use historical data for comparison, but these have to be very hands-on, very practical studies. So yeah, one element is definitely the aim of what you're trying to measure, but the study design also should really include an arm that is care as usual versus the intervention arm. We're not looking to see those sort of designs. And Gillian, I don't know if you want to expand.
Yeah, happy to. So I think for us, we're looking for interventions that have shown clinical effectiveness potentially by a randomized control trial and are kind of ready to be used on their own without the need for that control arm. So there should, you know, likely be appropriate safety netting and monitoring to make sure that everything is okay, but there shouldn't be the need for the for a control arm, because that is kind of study should have already happened.
Thank you. Question from Sarah. I think I can answer this, but I can be corrected by the team. So we've mentioned ongoing innovations in pancreatic cancer, liver surveillance, BRCA, Lynch and GRAIL, etc. Does that mean that we will be looking for innovations in other high-need tumour types for this call, or is there still space for additional innovations in pancreatic, liver, etc.? I think the bottom line is we're open to any call in any cancer type, and it's a meritocracy. It's based on, you know, its alignment and the best possible application associated with this call, whatever the cancer type. And there's no guarantee that any of these will be the complete solution. So Gillian, Peter, Katerina, please correct me if that's wrong. Okay. Tim says, could you provide a bit more information on the note on not funding projects aiming to influence NICE guidelines? In other words, is this saying that innovations that improve adherence and compliance to NICE guidelines are not to be considered? Gillian or Katerina or Peter?
I think I'll just start, and again, feel free to chip in, Gillian. This is more related to the comment we did earlier. It's also about the study design that would be required to only answer a research question. We're looking at very practical implementation, and the ultimate goal is to understand if your product can be used in the NHS. So if an outcome of what you're doing would also influence NICE guidelines, it would be great, but it's more related to the study design and what you're trying to achieve. Anything to add? Okay. I hope that clarifies.
That's helpful, Katerina, thank you. So relating to point 3 in the scope, that we're seeking to support streamlining referring pathways through risk stratification of symptomatic patients. Does this include an innovation to improve prognosis to risk stratified patients for decisions around chemotherapy or only around diagnosis? Hopefully that makes sense. I'm just reading word for word. Gillian or Katerina or Peter?
I think for us, the primary focus of this is early diagnosis. So if you can't demonstrate an improvement in early diagnosis, then this is probably not the right call. But if you can, then please do.
Now that's the end of the questions I have that are flagged for live answers. I don't know if the team has noticed any that I've missed, or if there's anybody who would like to add a question. There are some questions still being typed. Gillian or Katerina?
I'm having a look, and for the moment, there is maybe one. Yeah, I think that there is one the one from Mike Long at the end. Richard, if you don't mind to pick that.
Yeah, so regarding support and advice and implementation and overcoming barriers, there's always a challenge with IG and data sharing with trusts, especially where there are multiple sites involved within the evaluation. Are there any thoughts on standardizing data sharing agreements and leveraging the program to streamline the process, noting the challenge that each site will likely have their own processes already in place?
Go, you go on smiling because I know where this is coming from. Hi, Mike. So Gillian, go on.
As you know, for our own pilots that we run within NHS England, I think we also encounter some of these challenges. So I'm very sympathetic. I think we will support where we can based on things that we currently do within the programme, and anything that we can leverage, we will. I don't think I can wave a magic wand, but we are aware that this is an area where we do need to offer support.
Thank you. The 3 questions repeated. They weren't flagged for live answers, but I'll address them anyway. The last one, as I already mentioned, was, is there a specific list of cancers? We did answer that. The answer is no. Any cancer is eligible for this. As we've said already, provided it fulfills the call, the mission of the call, which is for early detection. There is a question from Charles, which is, are RTOs also eligible to apply as lead applicants? And what percentage are they funded at? 100%? Question mark. Katerina or Gillian?
Yeah, I was trying to unmute myself. Yeah, any legal entity can apply. So if the RTO is your RTO is a legal entity, can apply, and we fund 100% of any organization. But again, you need to be reasonable in your budgeting, and you need to budget a fair market value.
Yeah. Some other questions, because we have time, that aren't flagged as live answers, but Dawn's asked, is a randomized controlled trial required? I think that's what she means by RCT. This is unusual for care pathway interventions.
I don't think a randomized controlled trial is required. Examples of kind of things that we would be looking for as an evidence base might be a randomized controlled trial, or it might be something that's existing within a current trust that you're looking to scale. It's an appropriate evidence for the type of intervention that you have, so it doesn't have to be an RCT.
Yeah. Thank you. Question from Kevin. The presentation seems to suggest that the technology must already be in an NHS setting. Is this the case? Our application would definitely involve implementation in an NHS setting, but the technology isn't currently in the NHS. I think the answer to that is no, but Gillian and Katerina can answer that.
Yeah, I'll pick this is easy, Gillian. Let me answer this one. No, the answer is no. You don't have to be already in the NHS, but you must have regulatory approvals if you're not in the NHS. So check that. Gillian, did you want to add something?
Yeah, I think if you're not currently in an NHS trust, then it would be useful to provide some evidence why you think it would be feasible to implement and deliver the project within the NHS, but you don't have to currently be in the NHS.
Thank you. Can NHS acute trust supply secondary care in brackets or primary care networks? I think the answer to that is yes. Was that any legal entity can apply? Just trying to see if there's any questions that we've missed.
There was one about data, Richard. Someone has asked where does the data go? I think, let me see. Yeah, from an anonymous attendee, yeah.
State missed where diagnosis data should go. I'm not sure what that question means. That's why.
Yes, be philosophical.
That person could clarify that question.
Yes. But definitely, just to say that definitely something that we would like to use the data for is your independent evaluation. But yeah, maybe you want to clarify.
Yeah. So they clarified, where do you want the diagnosed to be filed? Trust stroke GP, I think. Maybe that's the same person.
I'll start chipping in. If it's an implementation study, the data should stay where they sit, where they would sit in a normal delivery setting. I understand that sometimes you have innovations that sit outside the IT departments, but this is for you to discuss with them in terms of, you know, your DIPA, what the data flow will look like and where they should sit.
Yeah.
I think that's.
I mean, I'd see from this in the previous question, if you're making diagnoses in patients, then clearly the information needs to go into the healthcare system. That's the point. This needs to be real life applicable.
Question from anonymous attendee. We've been trialing a service to diagnose melanoma at a very early stage, precancerous or stage 1, which has been effective with proof of current data. Will it be possible to potentially implement a multi-center approach? Gillian?
Yeah, I mean, this is exactly the kind of things that would be relevant, something that is done in one place that you're looking to scale and what the real world implications of trying to scale. So, yes.
I think the last question we've sort of answered, which is definition of use in NHS trust, please. We've had single uses in various trusts and are waiting for business cases approval for one major trust. Does that sound okay, justifiable?
Yes, it does.
Yeah. I'm just scanning to make sure we haven't. If it's unnecessary to be already implemented in the NHS, if we are already being implemented, might this be an advantage when applying to the programme?
Yes, it would be, because I think it would be a really good way of demonstrating that your intervention is feasible.
Yeah. Thank you from Dimitri. That was answering his question.
Also, maybe Richard, just to chip in terms of the way the application is structured, there will be 8 different criteria your application will be judged against. We will publish this in the invitation to tender, and the level of evidence and case for development is as a strong way. But there will be also other aspects you will need to be compelling for.
More time, so I just don't see any more questions. I'll give it another minute or so.
The feeling we probably you
Yeah.
grilled us, Richard. So
Yeah, I think that's I mean, that's fantastic questions, a lot of interest, so that's superb. So okay, well, I think we'll move on to the next part of the agenda. Peter is with us for another 5 minutes, but might be leaving. But Peter, thanks for your input. It's great to see you again. So I'm delighted to introduce now the next section, which is about Cancer Alliance support. Delighted to introduce Anna White from the program, who's a program manager with a joint role at Wessex Cancer Alliance and Health Innovation Wessex, who's got experience in supporting multiple NHS cancer program innovation and core projects. Anna, it's great to see you again. Thank you for being here.
Thank you, Richard, and thank you for such a kind introduction. Good afternoon, everyone. As Richard just said, my name is Anna Wykes, and I'm a programme manager from Wessex, which, if your geography is as good as mine, may not know where that is. So that sits on the south coast of England, covers 2 ICBs, which is Dorset, Hampshire and Isle of Wight, and covers a population of roughly about sort of 2.7 million people. If we can go to the next slide. As sort of Richard's alluded to already, I'm here today to kind of talk about the role that health innovation networks and cancer alliances can have within any application and successful project delivery can have. I'm not going to repeat what Richard said, but I'm lucky enough to have a job where I am co-employed by both a Cancer Alliance and a Health Innovation Network. So I've been working within and across both types of organisations for nearly 4 years. We've supported sort of 3 applications to previous open call competitions. So I have some insight into what can really help applications and project deliveries. And I just thought it was really stark to kind of go back to Gillian's slides previously, where she identified that 17 cancer alliances and 10 health innovation network teams were involved with the successful application. So hopefully that kind of gives you a sense of how important the role of both types of organisations can be. Before I kind of go into some of the real detail of the different ways that either organisation can support your application, I just wanted to kind of start off on the same page as everyone, because I know everybody will have a mixed experience of what a Cancer Alliance is or what a Health Innovation Network team is. I'm also really conscious that I have colleagues from both here today. So what I will caveat the rest of my slides with is that this is my Wessex experiences with how the organisations can work. There might be some regional variation, but I'm hoping that a lot of the points that I make will be pretty standard. Now, could we move to the next slide, please? So just to kind of start with what health innovation networks are, they were known as academic health science networks up until October last year, so AHSNs, which might be slightly more familiar to some of you. But fundamentally, the premise of health innovation networks was agreed sort of back in 2013. It's essentially funded part of NHS England, and we are seen as the innovation arm of the work that's done within the NHS. Fundamentally, you can see on the slide that there are 15 different health innovation networks. They cover different regions. So we operate locally. We work with local ICBs to understand what the local priorities, what the local needs are. But we also collaborate nationally. So there are pieces of work that all health innovation network teams will work together in. And even some of the local work that we're doing, we quite regularly touch base with each other to just share that learning and support each other with those pieces of work. ultimately, Health Innovation Network teams are uniquely placed to bring together the NHS, industry and academia to identify, support and implement suitable innovations. So the expertise from a Health Innovation Wessex or Health Innovation Network perspective is supporting that innovation development, but also adoption across different pathways. If we can go to the next slide, I'm just going to give you some context to that, because I start to slip into what we do in Health Innovation Wessex. So again, caveat, this is my experiences within working within Health Innovation Wessex. So as I mentioned, it's based on the south coast of England. And within Health Innovation Wessex, we're working with those two ICBs to identify what is needed from a patient and population perspective. And we have 3 core teams within the organisation to deliver that work. So I have colleagues within an innovation adoption team who work with the ICBs to identify what their priorities and needs are and kind of almost matchmake them with some of the innovations that we are coming across. I work within an industry and innovation team who I have colleagues who support innovators from across this whole spectrum of readiness. So I have colleagues who work with innovators who have got a really great idea, who need to understand how they can then develop it and progress it through, to people like myself. So I sit on the other end of the spectrum, where I work with innovators who, a bit like this call, have got their evidence, they've got their regulation, they just need support to implement a pilot or a project to prove that real world kind of implementation element. So there's a whole sort of raft of experience and expertise within that innovation and industry team as well, which then feeds into our IAT team. But also, and again, I think this came out of Mike's question to the panel previously around that evaluatory piece as well. So Health Innovation Network teams ordinarily have a evaluation team associated or within the organisation. Our evaluation team is called the Insight team, and they are really invaluable. They provide evaluation on our innovation projects. They also provide independent evaluations to projects that we might not necessarily as an organisation be involved in, but an evaluation is needed, and their role is to support the generation of evidence that informs the business case side of things. So once a project's ended, they talked about it in the panel before, about it's being really important that it's not just a piece of work that you're delivering a project to go, yeah, this innovation works really well. It's that long-term piece of making sure that actually, if it's proven a really positive impact, how do we keep it going? How do we keep that benefit available to the population, and how can we spread it? So they have a really important role in that. And just as an example of the sort of the impact that health innovation teams can do, in 2023, Health Innovation Wessex worked with well over 260 innovators and generated over £31 million, either through sales, investment and grants. So they can have a really significant impact on working with innovators. Can we go to the next slide, please? So not forgetting the importance of cancer alliances. And I think for me, the most important point on this slide is the first one. So cancer alliances are basically organisations, again, I'm not going to read them all out on the slide, but there's 21 across England, and they have a real fundamental role in that clinical leadership within cancer pathways. This is centred around the fact that they work with health and social care organisations to plan and deliver care across all the cancer pathways. So they really do know who the cancer partners for your projects would be. And yeah, and I think if I'm not going to ask Noel to kind of switch back to the previous couple of slides, but some of the cancer alliances and the Health Innovation Networks patches kind of align somewhat. So with all the cancer alliances, there will be a Health Innovation Network within that area who can support that any innovation adoption work. Now, if we can go to the next slide. And this is just to kind of give an example and contextualise sort of the impact cancer alliances can have. So in Wessex, this is their sort of impact from 22-23. You can see that there's a whole plethora of work, and you'll be relieved to know that I'm not going to read it all out, but it's just to demonstrate that there's a lot of work already going on within the cancer alliances, within different cancer pathways. So the involvement for me from a Cancer Alliance perspective is the fact that not only are they the sort of the clinical leadership when it comes to addressing and supporting development and improvements within cancer pathways, but there's a whole raft of work that's already going on that'd be really important that any project that you are designing fits in nicely with. I've experienced, not necessarily in the cancer world, but in the innovation world, that you can implement a pilot, whereas if somebody else is working on either the same pathway or a slightly different pathway, but you end up trying to do the same thing, it can cause quite a lot of challenge. So it's really important to make sure the local cancer alliances are involved. I also just wanted to highlight the setup in Wessex is they've got 5 core work packages where different members of the team are delivering different pieces of work. This particular open call directly impacts on 3 of them. So that's the workforce, the faster diagnosis, and the prevention and early detection. But actually, arguably, it could impact on all 5 of them because there's the personalised care element, which is becoming so important. And fundamentally, whilst we're not looking, as said previously, for the competition to be used to improve treatment, early diagnosis will impact on the treatment and care element. So again, these are things that you just need to keep in mind. Next slide, please, Noel. Thank you. So then just to kind of contextualise that when you have both Cancer Alliance and Health Innovation Network teams working together, I feel really fortunate that in Wessex that this actually led to myself being employed to deliver a programme of work where I can focus on the adoption spread of innovations for cancer. But just to kind of show that this is the 4th year that the piece of work that I've been working on has been delivered. I've directly project managed 5 innovation pilots or projects. I've supported 5 grant applications, 4 of which have been successful. That's generated over £1 million coming into the local systems to deliver those projects. My Health Innovation Wessex Insight team have been able to provide 2 independent evaluations. And we've identified loads of innovations, and I can't take credit for those over 300 innovations because actually, as I mentioned before, Health Innovation Network teams and Cancer Alliance teams regularly talk to each other. So there is a group of us that regularly share the work that we're doing. But I think it's a really powerful way of kind of contextualising actually why you should be involving your Health Innovation Network teams and your Cancer Alliances in your applications. Next slide, please. So I'm not going to read the bullet points, but for me, there's 2 parts and there's 2 roles that both organisations can have. One is as you're doing your application. So my advice to anybody who's looking to make an application is to write both types of organisations into the bid that you're making for the reasons that are on the slide. So from a Health Innovation Wessex perspective, we've had experience in helping teams write applications for lots of different grants for a long time, and I know that other health innovation teams have done as well. The insights that we have from supporting adoption spread of innovations across a whole plethora of readiness can really help influence some of the plans that you might be making, and especially around that commercialization, sustainability part. And that for me is a really important part of, that's a lesson that I've learned from applying for the open call, is that part has got to be really solid and clear. And as I've mentioned before, that bespoke independent evaluation is going to be really crucial as part of that sustainability aspect of your project, and health innovation teams can provide that. Every team will have staff who can provide quantitative, qualitative, financial support within that evaluation, and they can bespoke it to align it with the impact that you're looking to make, and what it is that your ICBs that you're hoping that will take up that innovation after the project will want. So they can really work with you to do that. And then from a Cancer Alliance perspective, it's that links to the cancer workforce, the partners that you will need to actually deliver the project, being able to introduce you to the right people to kind of get those conversations starting during the application process. I heard data quite a lot mentioned in the panel, and Cancer Alliances often have access to their local data, so they'll be able to help you populate some of your application with that. And this bit, it always gets missed off, but it's so important, is that access to the patient voices and representatives for the project. So again, I'm speaking for Wessex Cancer Alliance, but we have some really great patient public members who get involved with a lot of our projects, and we can bring them into any application. So again, just a few real important ways that we can support the application process. And then if we move to the next slide, after your application, there is even more reason to write both organisations in. Going back to Katerina's presentation, where she was talking through the process of what happens with your application once you hit submit. There is a process where it's reviewed, and if your application looks really positive, you get invited to a panel where you have to then present to a group of people of why your project is a good idea and why it should be funded. In previous open calls, we've provided a mock interview for that, and I don't know about anybody else on this call, but it can be quite nerve-wracking. It's like going for any interview. It's quite nerve-wracking to kind of sit in front of people virtually or face-to-face and explain why you should be chosen. So providing a mock interview from a health innovation perspective can be really useful. It gives you a chance to go through your slides, and you'll get asked questions of what you could be asked. So it kind of helps you prepare for any sort of inevitable kind of outcome that you get. So another really good reason to include your health innovation teams. I'm not going to read the slide at all, but just to emphasize that project management support. So the work that I've done, it's actually been a real key part of the way that we've been able to support and deliver some of the projects, but it has to be written into that application. So and again, you might not need a lead project manager for your work, but if you need support to do some of the project management from a local perspective, you still need to write that into your application, and both the health innovation teams and the Cancer Alliances can do that. They might have to recruit to it, so we have had to recruit to some projects, but that's okay, because as long as it's written into the bid and we know we're going to get some money for it, we can do that. So that could be really crucial. And again, I can't go back to this whole sustainability part enough. The Cancer Alliances know their commissioners, so they can start those conversations very early to help you with that planning, and then to keep them in the loop as the project's being delivered is a really crucial part. Yeah, let's move to the next slide, because otherwise I'll talk about that for ages. So just to kind of give you a real life example, and I promise, Charlene, I won't talk too much because I know you're going to share some of your experiences with some of the projects you've been supported to deliver, but this was one of our successful applications with Sighted. We were one of 3 Cancer Alliances, the others being East of England and Yorkshire, oh my goodness, South Cumbria team, where we have been delivering the capsule sponge test in the primary care community care settings, and you can see from the slide that pre and during the application, we helped galvanise local workforce together to get agreement to deliver the project. We got some local data, we supported writing the applications, and we provided that mock interview to give them feedback in preparation for their panel interview. And then since the project's been launched, we've provided direct project management, and we've been able to get public patient involvement as well. And we're already moving into the sustainability planning elements. So hopefully that kind of shows you that actually it's not me just sort of bigging up what Cancer Alliances and Health Innovation Networks teams can do. It's you know, we can be really a useful tool in your application. Can we just move to the last slide, because I'm conscious I've got probably about a minute. So in summary, there are lots of positives and strengths that we can bring you from a Health Innovation Network and Cancer Alliance perspectives. The slides will be shared with you afterwards, and if you click on the logos, they will take you to the links of the web pages where you will be able to identify the different Cancer Alliances and network Innovation Network teams that you want to connect with. But if ultimately you're thinking of doing any bidding, making an application, please get in touch with myself. I'm really open to that. And again, if you want to look at any of the evaluatory work that health innovation teams can do, there's a link there that you can access the portfolio that the Health Innovation Wessex team can provide. Sorry, Richard. 30
Brilliant.
seconds to go.
Perfect. Thanks, Anna. So lots of fantastic information. I know you'll be hanging around for the last Q&A, so thank you so much. That's great. So as alluded to, we're going to now go into 2 5-minute sessions and just reporting on 2 progress and 2 of our winners. The first one comes from the second round winner, that's from Charlene Tang. And she is head of growth at Cited, and through the second open call that they won, Cited is piloting the use of a non-endoscopic approach called Endosign in primary care to proactively identify patients at risk of esophageal cancer. Thank you, Charlene.
Thanks, Richard. Afternoon, everyone. As Richard said, my name is Charlene, and as head of growth at Cited, I'm here to share a little bit about how we can make a difference in the earlier detection of esophageal cancer and how NHS England Cancer team and SBRI Healthcare have supported this. Next slide. Now, you'll recognize the figure on the bottom left from Peter's slide earlier. Esophageal cancer is a public health concern. We've got 80% of patients diagnosed late when they've got less than a 20% chance of surviving that year after diagnosis. So we clearly need tools to detect esophageal cancer earlier, especially because we have treatments that are curative at that stage. And that's where the capsule sponge test comes in. It was invented back in 2001 at the University of Cambridge, so it's evidenced by over 10 years of clinical trial data and the last 3 years of real-world implementation. So it's effectively a pill on a string. You swallow the pill, and in your stomach, the capsule dissolves, releasing a little sponge. After 7.5 minutes, your practitioner can retrieve that sponge through your mouth, collecting cells along your esophagus along the way. We look at those cells at the Cited lab and tell your clinician whether there's any signs of cancer. Next slide. So when the pandemic hit in 2020, real-world implementation was accelerated. So we were part of the early 2020 Horizon Scanning Call alongside GRAIL and colon capsule endoscopy. So we've had the benefit of national pilots with NHS England and Scotland over the last 3 years. However, those have focused on hospitals-based clinics because that's what was open during the pandemic. So really, the innovation call and SBRI Healthcare have been key to translating what we've learned in hospitals and clinical trials to community care when GPs opened up. And this has really helped accelerate national adoption and uptake with the latest data and evaluations informing clinical pathways. Next slide. So I'm just going to briefly touch on our Cytoprime 1 project, which really sets the scene and the foundation. Back in 2021-22, remember, GPs were closed and they were slowly opening up again to innovation. So here, this is where everything started with the HSN, now HINS, and Cancer Alliances in the Northwest, realizing they needed to do things differently. So it's a small project, brought together 6 partners, set up 5 community-based clinics, really showed success and immediate impact, recovering surveillance backlogs for endoscopy, for disparate surveillance, for all 4 localities within 5 months of clinics, saving endoscopy resource and demonstrating sustainability. So really, this was the first stepping stone that we took for Cytoprime 2, which is on our next slide. So this was our innovation call project with support of NHS England and SBRI that started in 2023. Much bigger scale. We brought together 7 partners across different corners of England with 3 cancer alliances. You've already heard from Anna at Wessex, and we had Lancs and South Cumbria from Cytoprime 1 and East of England joining us to really show what this would look like in the real world across the UK. This time we focused on community-based clinics to validate what was shown in the clinical trials in the real world, showing that it could be sustainable for ICBs. Next slide. So with my last minute, some quick fire advice on how to approach the application in the project. Don't underestimate how much time this will take. Now, I led on the process for both proposals, both times, and I wish we had learned from some retrospective on what we do differently. I was grateful to have had ongoing discussions with partners already and a really clear focus on what their needs and priorities were in the NHS. So we were systematic with our answers and really focused on what value add we were going to get out of the funding that we were asking for. I got several providers for evaluation. I got several quotes from them to make sure we were really looking for what we got, and had several practice interviews. So made sure by the time we came around to the panel, we weren't too fazed by the curveballs that were thrown at us. So that was really great. Next slide. In terms of the actual delivery of the project, now, of course, Cytoprime 2 is still going, but I think the really key bit is support from your regional team is critical for implementation. So both from the Cancer Alliance and your clinical teams, having that dedicated project manager, just like Anna and co, is really key for that leadership and that point of contact on the ground, because that engagement for feedback and implementation is key, as well as clinical buy-in. DPIA, so the data and the IG, is always going to take longer than you'd expect, so make sure you schedule enough time for that in your project plan, as well as meetings at least 6 weeks in advance for your clinical leads. We really valued our investment into understanding the patient journey, pathway mapping through the SBRI support, and the meta tool, NICE tool has been really invaluable to understanding what the gaps were. And critically, the PPIE, the patient public engagement involvement, has been super key and should never be an afterthought, especially knowing that you've got those resources in the AHSNs, Cancer Alliances, as well as national or local patient advocacy groups. So to close, I'm just going to underline how invaluable Katerina, Chris, and the team at NHS Cancer and SBRI have been to all of this. I would encourage everyone to be upfront and open with your communication. It's better to flag any potential risks or issues upfront so you can mitigate these and tackle challenges together. So that's we can skip to the next 2 slides, and you're happy to take any questions.
Yeah, we'll do those in the Q&A. Thank you. That's great. So for time, we're going to move on to Dr. Angela George, who's the Clinical Director of Genomics and a consultant medical oncologist at the Royal Marsden Hospital. And the Royal Marsden was an NHS Cancer Programme Innovation Call winner in the first round. And their project is on whole body MRI for diagnosing cancer early for patients with Leigh-Fraumeni syndrome. So Angela, thank you for your presentation.
Thank you, Richard, very much for the introduction. It's a pleasure to be here to talk today about our Signified program, which was looking at taking patients with a very high-risk gene syndrome called Leigh-Fraumeni, which is caused by inherited gene alterations in the TP53. Sorry, I'm just trying to advance my slides, but it's not working.
Are we able to do that from the office? Yeah.
Yeah, you just need to say next slide and we'll move on.
Brilliant, thank you. So Leigh-Fraumeni is as I said, thankfully rare, but is when inherited by an individual, causes them to have lifetime risks of developing cancer of up to 90 to 100%, respectively for men and women. And most of these individuals, if they survive their first cancer, will go on to get multiple cancers. They can get any type of cancer, but typically they have a high risk of getting breast cancer if they're female. They can get a lot of sarcomas and brain tumors, and then a number of basically very rare cancers. They are also particularly susceptible to environmental factors, so things like ionizing radiation and cigarette smoke. Next slide, please. So it's been known for a while that undertaking a single whole body MRI is a very effective way of trying to find these lesions at an early stage. And we use whole body MRI with diffusion because you can basically look at the entire body in one go. It takes about an hour and 20 minutes with the current technology to do this, but it's a very sensitive way which doesn't expose the patients to any additional radiation. However, at the time at which we set up the Signified study, whilst this is recommended in all of the national and international guidelines for TP53 cancer patients, it wasn't actually commissioned across the NHS. Next slide, please. So our plan was to take patients with confirmed TP53 mutations who were asymptomatic at the time and were at least 5 years out from a previous cancer diagnosis, and undertake 2 whole body MRI scans with diffusion with 12 months in between. So basically a baseline scan and then another one a year later. The aim of this was firstly to look at the prevalence and detection of cancers in these patients, but also to start looking at the sensitivity and specificity of repeated whole body MRIs, because we know from similar studies, such as those using breast MRI screening for women with BRCA mutations, that the first time you do an MRI scan, you have up to a 25% recall rate for potential abnormalities, but that drops down to less than 3% with repeated scans as you start to have a baseline for comparison. So we were very keen to look at this impact as well on repeated scans in these patients. Next slide, please. So basically, we were aiming to get at least 50 patients. We actually recruited 55 in total. Over 12 months. Predominantly, these were female, and they were on average around 42 at the time of entry into the study. You can see that we predominantly had patients from London and the southeast, but we also took patients from around the country, including the devolved nations, where this testing is also not currently available. We have now had all 55 had their first scan, and we've just completed our 42nd patient for their second scan 12 months later. Next slide, please. So this is just to show you what we found with the first round of our whole body MRI. So these were basically baseline scans. We had 32 scans that were completely normal and didn't require any follow-up. And then we had 23 scans where we found something abnormal. 5 of these were benign findings and didn't require any further investigation. 18, however, did require further investigation. 1 of these turned out to be a false positive. 8 required a different type of scan to further investigate something that looked suspicious and were found to be okay on repeat testing. We recommended biopsies for 9 patients, of whom 4 had confirmed cancer and 5 had benign lesions confirmed on biopsy. Next slide, please. We have now, as I said, completed 42 scans. This slide is slightly old because we prepared it last week as we're still waiting for the final results. We have, in fact, at that time, of the 35, we had 26 with no abnormalities. We're now up to 40 scans with we've now got a further 31 scans with no abnormalities. We have a further 2 scans that are abnormal. We have recommended biopsies in 7 patients. We now have 5 confirmed asymptomatic cancers, and we have 2 biopsies pending. And we have further follow-up recommended for 2 patients. You just go to the next slide, please. Can see on the first side are the patients with tumours that we found in the first round of scans. So we had an astrocytoma, so a brain tumour. We had a very early lung cancer in a non-smoker, a pancreatic cancer which has been able to be treated with curative intent, and a leiomyosarcoma of the leg. In our second round of scans, firstly, we found a patient who had an isolated nodal recurrence from a breast cancer that she had been treated for 14 years ago. We found another patient with widespread DCIS grade 3 throughout one of the breasts who had had a normal MRI scan of the breast only 6 months earlier. We had a retroperitoneal sarcoma. We've had a standard uterine cancer, and we've also just had a confirmed uterine sarcoma as well on the most recent abnormal biopsy. Next slide, please. So we had set up this to have a full cost effectiveness analysis, which is now underway with our health economics team. We're looking at the cost effectiveness of undertaking the screening, and of course the fact that all of these tumours have thankfully been picked up at very early stages compared to the average stage for each of these cancers, with the exception of the finding of the isolated metastatic disease. We are now also have been informed by NHS England that they are looking at taking this on as the standard of care for patients across England with Lee-Fraumeni syndrome, which we're very, very excited about. Next slide, please. And just to thank you, huge thank you to all of our team, particularly our amazing radiologists who have double read every scan and been fantastic. They're also now in the process of undertaking a national training program for other radiologists who will be involved in reading whole body MRI scans for these patients. And a huge thank you to the rest of the trials team who've been dealing with these patients, particularly my amazing fellow, Elena, who's done much of the work. Thank you.
Great, thank you, Angela. So I'm going to ask Angela to stay on and also invite Anna back along with Katerina and Gillian so we can have our final Q&A session. I'll just start again by reading out these in order for those that have been requested sort of live answers. The first of those was actually from the previous session, which is, are there any innovation programs in paediatric oncology involving early diagnosis? And they'd be interested in learning more about that. Gillian or Katerina?
I think
Go on, Gillian, sorry, go on.
I think this is where I think Cancer Alliances and Health Innovation Networks can really help because they have a really good oversight of what's happening within their area and, you know, potentially a wider network as well. So if you're looking for things to link up, they are a really good source.
Right. Next question is, can you give an example of the distinction between a solution already in usual practice, but the outcome is an evaluation? Often to become usual practice, i.e. out of pilot, evidence is already available. So I'd like to understand the distinction you're making. So could this be an existing solution with a new partner looking at a specific demographic, for example?
I can pick that up. Yeah, so if you're looking to move into a new demographic or even in a different type of location, if you're in one area and it's a, you know, an urban population, but you're moving to a different site that's more rural, I think there's different evidence that we would need to collect about how easy is it to implement. Are you still getting the same uptake rates? Are there any other barriers that need to be overcome? Is it still cost effective at scale? So that's, I think, well, the kind of thing that we're looking at for.
Great, thank you, Gillian. I think that answers the next question as well, which is, are solutions that are already being used in the NHS but modified to reach hard to reach populations eligible for the course? I think that's the same. There's no such thing as a silly question. This is from Lynn, who says it's a silly question, but if we want to run a multi-centre study across more than one region, would we need to involve multiple healthcare innovation networks and or alliances?
I'm happy to take that one.
Take that, yeah.
Yeah, I'm happy to take that one. My advice would be I would at least approach them all at the beginning because depending on what you're planning, you might need support across each of those regions, and that support can come from the Cancer Alliances and the Health Innovation Network teams. And to be honest, working within both, it's just quite nice to know that that sort of work is being planned. I think maybe going forward, you might not need direct involvement from all of them, but I would strongly suggest you approach them all. And again, like I said in my presentation, Health Innovation Networks and Cancer Alliances all talk fairly regularly. So joint conversations with all of them, I would recommend, and just to feel whether they all need to be involved going forwards.
Thanks, Anna.
And Richard, sorry, go on. I just wanted to chip in to say also, if you're interested to connect with Cancer Alliances and Health Innovation Networks, we are running, as a reminder, a matchmaking event soon. So yeah.
I'll mention that at the end, Katerina.
Thank you.
Question from Jonathan again for Anna, but SBRI can chip in, which is what costs from a Health Innovation Network or Cancer Alliance should be included within an application, or would some of the support be provided free of charge?
That's a really good question. I think my response is it depends on the type of support that you would need, and some of the projects, you know, we've offered some specific kind of lead project management type support. Others, it's been sort of bespoke kind of insight provision, which could be provided free of charge. So, Jonathan, I know that doesn't directly answer your question, but I think this goes back to talking to both the Health Innovation Network teams and the Cancer Alliances to talk around what is it that you need and what is it that they can provide. As I said in my presentation, you know, we have in previous projects employed somebody specifically to deliver some of that project management or evaluatory kind of support. But the cost will depend on the time and the experience that you're after. So yeah, please just talk to the Cancer Alliances and the HINs, and they'll be able to give you those costings at no problem.
Great, thank you. A question from anonymous attendee: how do we organise an independent evaluation given the restrictions around sharing NHS data? Gillian, do you want to pick that one up?
Yeah, so I think as part of the evaluation strategy, you can consider how you will handle the data, and that would be part of it. I think health innovation networks can also advise on evaluations and how best to do them if you don't have an obvious partner. Other projects have partnered with academic institutions who've done their independent evaluation, and they have experience in data handling and confidentiality and the IG requirements.
Great, thank you. Question from Emma: where innovations have received funding in previous rounds, will this have a bearing on whether applications to spread and adopt in other regions would be accepted or not? For example, the capsule colon endoscopy. Is it possible to have access to a list of innovations which have already been supported?
Shall I chip in?
Yeah, it's Katerina.
Yeah, so in terms of list of innovations already supported, they are available on our website, so you can find them there. And these innovations would be eligible only if they are generating new evidence. We wouldn't really be funding a copycat study that generates exactly more of the same evidence, but you might need to think about different type of patient population, I don't know, rural versus city setting or different clinical settings. So you need to be changing something if you want to apply again so that you generate new evidence with the same innovation.
Great, thank you. Question from anonymous is there a list available of who best to contact in each region for the Health Innovation Network and Cancer Alliances? And would we approach Cancer Alliances through the Health Innovation Network?
I'm happy to take that one. I mean, so if my slides get shared, there is you can Google Health Innovation Networks, and there's a main network. There's a lead team who oversee all the work that is delivered over the Health Innovation Networks, and they will identify. They'll have links that go to the separate Health Innovation Network teams. I think going through Health Innovation Networks to the Cancer Alliances. The relationships between Health Innovation Networks and Cancer Alliances is still developing. So some will have a really strong connection, as we do in Wessex. Others, it's still fairly new. So I would still probably suggest you go to both, and just maybe when you start having those conversations, just check that the two are talking. I think now, Katerina, Gillian, I think most are sort of linked up with their relevant partner sort of organisation, but yeah, my advice would be is to click on the links, Google the Health Innovation Network teams, the Cancer Alliance teams. All the details are online, and to reach out to both, but to try and have conversations with both together, so you're all kind of on the same page.
Thank you, Emma. Question from Lynn: could an initial bid be a pilot study only, with a subsequent grant application for full cost effectiveness if the pilot was successful, or should the pilot be an internal with a full cost effectiveness application? Maybe Katerina?
I'll start. We were really, I think the ambition that we have is that we would like for the benefit to be as broad as possible. So if the impact you can achieve is on multiple sites, it will be preferable. However, depending on where you are in your development process and what evidence you need to generate, you might choose to do something which is a little bit more local. But it depends on what you intend for internal pilot as well. We did fund in the past some projects that were focused on 1, 2, 3 on a local scale, but this has to be appropriate. So I hope that covers. Gillian, I don't know if you need to say anything else.
Yeah, I mean, I think with all these things, it's a balance between impact and feasibility, and it's more impactful if you have a much larger pilot and you can generate more evidence. But if it isn't something that can be delivered within 24 months, then it's not feasible, so therefore is unlikely to be funded. So yeah, striking that balance.
Okay. I don't see any more questions. We're nearly at the end of time. So really, it's just to thank everybody for all of the presenters for doing such a great job, particularly for keeping to time, which is great, and all of you for attending and your questions, which was great discussion. Thank you, and Peter for his absence, who's gone now, but thank you everybody for participation. Just to remind you about the upcoming event. So there's a matchmaking event, which was referred to earlier on the 12th of March between 2 and 5. Please refer to the website if you need any more information on that, and keep looking at the SPRI healthcare website because that information is updated regularly. But with that, thank you so much for your attendance. Please feel free to contact SPRI if you need more information about this. We look forward to joining you more in this program as we move forward. Thank you so much for your time.